Good morning, everyone. We're just going to wait another minute or so while people join the webinar today, and then we'll get underway. Okay, we'll make a start. Good morning, everybody. My name's Rachel Morton, and I'm a Professor of Health Economics at the University of Sydney and President of the Health Services Research Association of Australia and New Zealand. Welcome to our monthly webinar series. And before we introduce our speaker for today, I'd just like to make note of a couple of events that are coming up for the association. The first one is a training workshop on the 26th of October on infographics, how to design and use infographics to communicate your research. And registration information for members has gone up on our website. So that'll be an excellent 2/3 of a day training session on the 26th of October. The other thing to let you know of is that our end of year event will be on the 2nd of December this year, celebrating health services research. And I encourage everybody to look at the preliminary program and to register for that. That will be a virtual event. And finally, although this is a monthly webinar series, we actually do have 2 webinars this week. So to remind you that on Friday of this week at 11 o'clock, we'll have a webinar on step-wedged cluster randomised trial designs. Okay. So without further ado, I would like to introduce our speaker today, who's going to talk for about 40 minutes, and then we'll have time for 10 to 15 minutes of questions and answers with her. And if you could please use the Q&A button rather than the chat button, because the chat button comments sometimes distract the speakers. And then I will facilitate the Q&A so that our speaker is able to respond. So it's my great pleasure to introduce a colleague from the University of Sydney, Professor Cathie Sherrington, who's a professor in the School of Public Health and leads a 23-person physical activity, ageing and disability research stream within the new Institute for Musculoskeletal Health. And this institute is a partnership between the university and Sydney Local Health District. And Cathie is Deputy Director of the Institute. She's also a Fellow of the Australian Academy of Health and Medical Sciences and the Australian College of Physiotherapists. Professor Sherrington is a globally recognised leader in the prevention of falls and the promotion of physical activity in older adults and people with chronic disabling conditions. And she's been awarded $26 million in Category 1 funding, with 8 grants as lead chief investigator, including a CRE in prevention of falls injuries. Professor Sherrington's publications include 272 refereed journal articles that have been cited over 31,000 times and used in at least 38 guidelines from 15 countries. So there's demonstration of impact right there. Thanks very much, Cathie, over to you.
Fantastic. Thank you very much, Rachel. And thanks very much for the opportunity to speak and also the opportunity to learn a bit more about your association. I was, had a good look on your website and I was most impressed, and we'll definitely look at joining up. So I'm going to talk about implementation of effective fall prevention strategies in the health system. So I'm going to overview the problem of falls. I'm going to focus on fall prevention interventions in the community and with a focus on exercise, and I'll overview some of the evidence of effectiveness, talk a little bit about cost effectiveness, and then talk about uptake, and then some sort of possible solutions for doing better. And yeah, I look forward to having some discussion at the end as well. So in terms of the problem of falls, as I'm sure you're very well aware, falls are a major and increasing problem. And so 1 in 3 community dwelling people aged 65 and older will actually fall each year. And that's actually 1 in 2 in high risk groups. And so the Australian Institute of Health and Welfare has looked at this recently and have found that unfortunately the rate of fall-related injuries in Australia are actually increasing from 2 to 3% per year. And that's after considering the changed age structure of the population. And so falls obviously can result in injuries, so that's sort of hospitalisation data. But even if they don't, they can actually be part of, unfortunately, a downward spiral for people, where people can suffer a loss of confidence, a further reduction in activity levels, and then, unfortunately, with reducing their activity, they then can actually become at greater risk of falls due to being less physically able, which can also lead to less independence, less community participation, and also residential aged care admission. So the risk of admission to residential aged care is around tenfold for people who've had falls. And so in there's obviously, that's the personal impact. There's obviously quite extensive health system impacts as well. And so this modelling is quite old now and is actually starting to play out, which is modelling of the cost to the health system of falls. And you can see that really because of the changing age structure of the population, that the absolute cost is expected to increase exponentially in this first half of this century. And so they've calculated that Australia will actually require over 3,000 nursing home places and 2,500 hospital beds to cope with this at a cost of over $1,000 million per annum. So in terms of trying to understand how we can prevent falls, a key thing is really to ask people why they fell. And this is work from Stephen Lord's group. This was from a cohort study where they followed people recruited from the electoral roll for a year and looked at people's reported reasons for falling. And really trips, slips and a loss of balance and weak legs together are really the major causes. So a number of our medical colleagues might be more focused on sort of dizziness and fainting, but these certainly are causes of falls, but the vast majority of falls are actually due to really things that happen while walking, so tripping and slipping and losing balance. And so to try and understand that, I've kind of over the years developed this this figure, which really shows the interaction between the person's physiology, their behaviour, and often environmental triggers of trips and slips. And so it's easy to think that the environmental hazards are the problem, but really the issue is more about the person's physiology and also the behaviour, what they're choosing to do with that physiology. And then there's obviously further back causes in terms of diseases, medications, ageing, inactivity, cognition, attitudes, and also distraction can be quite a big one as well. And so if we have a bit of an understanding then of falls, it makes sense that exercise might be a key strategy for preventing falls. And so we undertook this Cochrane review, was published in 2019 now, And we found a large body of evidence. So there was actually 108 trials altogether, 59 that looked at the rate of falls. And these are trials that are comparing exercise programs with control. And basically we're finding a 23% reduction in the rate of falls, and using the rigorous grade approach, a high certainty of evidence. And so Cochrane now, as I'm sure you know, likes to turn the results rather than relative reductions into actual real numbers. And so because falls are so common, the interventions can really be very impactful. So if you were to follow 1,000 people for a year, there would actually be 850 falls without this type of intervention, and 195 fewer falls with these types of exercise programs. We also did various subgroup analyses to look at whether there was any evidence of a differential effect on how you recruited participants to studies, the age of people in studies, and if you delivered interventions in a group setting or individually. And so there was no evidence of differential effects on any of those. There's less certainty about the probably more important bigger picture outcomes. And so the reduction in the rate of fall related fractures is actually in the similar order. But there's those studies, there's very few studies, and so it gets a grade rating of low certainty evidence. Similarly for falls requiring medical attention, only 5 studies with 1,000 participants, and also low certainty evidence, but still promising effect sizes. We did find differential effects for different types of exercise. And so exercises that particularly challenge balance and exercises that are sort of relevant to daily tasks, such as standing up and walking, so what we call functional exercises, were particularly effective. And there's also high certainty evidence for that type of exercise. Multiple types of exercise, and so these trials really combined balance and functional exercises with resistance exercises, and here there was moderate certainty evidence, and so with grade we can say they probably reduce falls. Tai Chi, there was actually low certainty evidence, so here we're saying it may reduce falls, but also similar types of effect sizes there. But we were actually uncertain of the effects of programs that just include resistance training, just include dance, or just include walking. And so although we know that overall there's lots of benefits of physical activity, and we know that there's lots of benefits of resistance training, in terms of falls prevention, it does seem that we need to be focusing more on balance and functional abilities, which kind of makes sense. And so here's this is an example of one of the programs that was found to be successful in multiple trials. So the Otago home exercise program from New Zealand. So these are the types of exercises that are included there. And so for the first time, the WHO 2020 guidelines or the update of the WHO guidelines from 2020 actually mentioned falls. And so that's the main paper from the guidelines published in the British Journal of Sports Medicine, and that's the fuller guideline document. And so the recommendation actually, as I said, mentions falls for the first time, and suggests that that older adults undertake multi-component physical activity that emphasises functional balance and also strength training on 3 or more days a week to enhance functional capacity and to prevent falls. And they've said that's a strong recommendation. And so this is over and above their recommendation about overall physical activity, but it can also be part of that, of the overall physical activity. And so that's how it comes out, saying recommending the muscle strengthening activities and also the multi-component physical activity. So we've, in terms of trying to understand the implementation of these types of interventions, we've worked with health economists and have actually done some analyses of cost effectiveness because we've really worked out that these interventions are highly effective, but our systems don't necessarily have a way to deliver these types of interventions. And so this was modelling that we did with Kirsten Howard. And so it was a Markov model looking at the and finding an ISA of 28,000 Australian dollars, the cost per QALY, and that was assuming a program cost of $700 per person and a risk ratio of 0.75, so a 25% reduction. Which would be considered cost effective at the if you were to adopt the threshold, which I understand is sort of informally adopted in Australia. And so, you know, as I said, we have good systems for delivering and for funding cost-effective pharmacological interventions, but it's a bit less clear how we would actually roll out these types of cost-effective interventions. And so what we were modelling was if you were to actually be delivering a program where you're actually providing exercise for people. And so we considered costs, such as hospitalisation, residential care admission, and quality of life associated with those. And so this is one of my favourite parts of the paper, and again, really guided by Kirsten. I'm not a health economist myself, but we were able to do one-way and two-way sensitivity analyses to look at when the program could still be cost effective with different costs of delivering the program and different reductions in falls. So yeah, I think that's quite exciting and potentially quite useful for guiding practice. But let's talk a little bit about the uptake in terms of what is actually happening. And so in New South Wales, I was involved in this work led by Daphne Marom, which was a random dialing telephone survey of 5,500 New South Wales residents. And it asked people about the types of physical activities that they undertook. And so you can see here that around 80% of people are actually undertaking walking, but only 12% doing strength or resistance training, 8% group exercise. And we also looked at other activities that might be challenging balance, such as bowls, balance training, golf, dancing, tai chi, tennis and yoga. And you can see that at a population level, there's extremely low levels of participation. And obviously, as Rachel said in the introduction, with my background as a physiotherapist, I'm quite active myself and tend to know a lot of people who are active. And so I think you do get a bit of a skewed view of how active the population actually is. And so similar findings have come out in other places. So this is a slide from Adrian Bowman. And so it comes from the National Health Survey, survey of 12,000 adults. And so that's looking at people of different ages. So the first figures there are the people who are meeting the guidelines about moderate and vigorous physical activity. The next is the people who are meeting strength guidelines. And then the next is the people who are meeting both guidelines. And again, they're extremely low. We also have done some work with the AusPlay survey, and this is from Leanne Hassett from my group. And so this is another representative survey of 54,000 people. And this looks at leisure time physical activity. And this was interesting in that, because we always say that physical activity participation decreases with increased age, and you saw that on the previous slide. But with this analysis, we found that it was actually people who reported disability who particularly decreased their physical activity with increased age, whereas the adults who didn't report disability actually had fairly consistent participation in physical activity rates over the life course. So that also gives us some clues, I think, about the types of interventions and that we need to implement, and who we might need to target. So obviously, if we're interested in changing behaviour, we need to understand the behaviour. And this was some qualitative work that we did, which was a meta-synthesis involving studies, qualitative studies in a total of 6,000 people. And here we're very much guided by Alison Tong in the methods of this. And so key themes that came out in people's participation in physical activity were social influences, physical limitations, competing priorities, access difficulties, so in terms of physical access, but also in terms of costs, people's perceived personal benefits of physical activity, as well as their motivation and beliefs. And so, you know, really we can see that the behaviour is actually quite complex and multifaceted and is influenced by a lot of different factors. And so that's where I think systems approaches can really help us sort of understand the complexity and also can help us develop interventions. And so this is the nice document by colleagues at the Prevention Partnership Centre, so Getting Australia Active, where they're highlighting the range of different influences on physical activity in Australia, which I think, as I said, is really helpful. And I think this is quite relevant in this area. So physical activity itself has been described as Cinderella risk factor by Fiona Bull and Adrian Bowman. And they talk about issues with lack of ownership of the problem and also of the control of relevant solutions being beyond any single government ministry, as well as insufficient use of advocacy and communications to make the case strongly. And so I think that's definitely, both of those factors definitely apply here. And I suspect that we have an additional issue with ageism as well, with people basically not expecting to be active, not expecting that people can be active with increased age. So the broader physical activity literature, I think, and advocacy really helps guide us with potential solutions, I think, as well. But unfortunately, in both the physical activity and the falls prevention area, much of the research is observational rather than actually developing and testing interventions. And so this was a nice analysis that Andrew Malat did, I think as part of his PhD, which found that, you know, overwhelmingly research in these areas is descriptive. And so to me, the WHO document, the Global Action Plan for Physical Activity, is really a helpful model for looking at ways that we could actually be intervening to help better implementation of the types of physical activities that prevent falls. And so this GAPA model talks about active societies, active environments, active people, and active systems, and it has a whole range of different actions under each of those. And so I'm just going to go through and give some examples of work that's being done, or, you know, has already been done, or is planned in some of these different areas. And so we actually did, we were actually commissioned by WHO to look to do a scoping review to look at what was known about physical activity interventions for older adults using that GAPA framework. And we basically found that there was actually very little research looking at the active societies and active environments aspects of that, but there was actually quite a lot of information about the active people, which is particularly programs and services. But back then to active societies, and so what they really talk about here is the importance of social norms and attitudes having that kind of subconscious influence on behaviour. And so here, strategies that people are using is sharing success stories and also a bit of practicing what we preach in terms of being active and modelling being active ourselves, and encouraging really all health professionals to do the same. And so we, in the first part of the pandemic, developed a website, Safe Exercise at Home, which sought to give information on physical activity and exercise for older people. And as part of that, we have a number of different success stories of people just sort of telling their story about how being active has benefited them. And so then active systems is really about evidence, but also advocacy. And I think in the falls prevention area, we've not at all been good at advocacy, but we are trying to get better. And so with our Cochrane review, I was lucky enough to be interviewed by Norman Swan, so on the health report before he became COVID famous. And so this is really, I think, part of trying to get the message out there to the general community, but also to health professionals who might be in a position to be influencing behaviour of people that they're seeing. We were also fortunate to get some coverage from the Times in London, as well as New York, actually. And this was actually helped by the Australian Cochrane Centre people. Really, even though our Cochrane review was at an overseas review group, overseas-based review group, the Australian Cochrane Centre media people did a fantastic job getting the message out there. I mean, it's interesting that both this and also the health report story did focus on Tai Chi, but that's actually not where the strongest evidence is. But I think that's a good message in terms of that sort of something that people can understand and can kind of get their head around. So we've also got a webinar coming up to also try and get the message out there about the benefits for older people and people with disabilities about being active. And so we're trying to use the opportunity of the lockdown, as well as the real risk of actually increasing falls at the moment because of deconditioning. And also with the restrictions, particularly in Sydney, easing, and with people's interest in returning to physical activity in a safe way. So we're working with a number of other organisations to host this webinar, and again to give information and also examples of success stories. The other thing we did, our group was previously at the George Institute, and we worked with the media people there, and we made a short film which we showed at the Run Nation Film Festival, which was also about the older people in several of our studies, and how they'd managed to really become more active and really have a lot of personal benefits from that. And that's freely available as well. But as I said, most of the research really is on programs and opportunities, and so ways that we can actually be creating active people. And so to me, how this sort of fits in with health services is about health professionals prescribing exercise to the people that they're seeing. And also about having quality programs available, either through health and through community mechanisms, and also health professionals referring people that they're working with to community exercise. And so in terms of the health professional aspect, we undertook actually a randomised trial of a fall prevention education program designed for health and exercise professionals. And so that was physiotherapists, also occupational therapists, exercise physiologists who might be working directly with older people. And so this workshop really focused on what the evidence was and practical ways to actually implement that. And basically we found, you know, so as I said, it was a randomised trial, a waiting list controlled trial. And we found that attending the workshop significantly improved knowledge, improved their perceptions of behaviour, confidence, and the proportion of evidence-based exercise that was prescribed. But again, this is self-reported, so we need to be a little bit cautious about it. But yeah, it was an indication that the workshop was well received. And we're now working with the New South Wales Falls Network, which is funded by the Clinical Excellence Commission, to sort of further roll out this type of training for health professionals, also with an online course. And so another thing that the New South Wales Ministry of Health has done is implement the Stepping On program. And so the Stepping On program was evaluated in a trial by Lindy Clemson, a colleague at the University of Sydney, and it found a 30% reduction in falls. And this program has been rolled out across New South Wales, and it's basically a discussion-based program that does also include exercise, and it's meaning to be kind of a group-based discussion with an aim of behaviour change and sort of group problem solving and sharing experiences. So yeah, as I said, aiming to build self-confidence, making decisions and behavioural change. And there's also guest speakers who you know, cover each of those areas, as well as home-based exercise based on that Otago program that I showed you previously from New Zealand. And so we did a bit of a study following people up who'd attended the Stepping On program, a pre and post analysis. Oh, and in both of these, I'll acknowledge Anne Tiedemann, my colleague at the Institute for Musculoskeletal Health, who led this one, as well as the health professional education trial. And we found that people did report ongoing behaviour change in terms of undertaking regular strength and balance exercises, as well as using some of the safe walking strategies that were talked about. Interestingly, so a lot of the other behaviours did not change so much for other aspects of falls prevention, but yeah, it was pleasing that those exercise aspects did change. The other thing the Ministry of Health has done in New South Wales is this Active and Healthy website, which enables people to find classes, so find an exercise program. And at the moment, it includes a lot of online classes as well. Actually a previous version of our systematic review was used to help guide the inclusion criteria for a program being called a fall prevention program on this website. But in New Zealand, they've actually done a much better job. I'm not sure if anyone from New Zealand's here today, but yeah, they've done through the accident, the ACC, I forget what it's called, Accident Commission. Yeah, they've actually had a program for supporting people, supporting local community providers to be providing exercise classes for people and really kind of clear links with health to refer people into that, and a system for actually accrediting the community groups who are providing the classes. And so they're doing this through a kind of network of organisations who then support the organisations on the ground. And I think it's a fantastic model and something that we could really learn from in Australia. But as I mentioned, a key aspect, if we are looking at what the health system can do, is to really be encouraging health professionals to be encouraging their patients who they're seeing, any older person, to attend the type or to commence the type of exercise programs that have actually been found to prevent falls. And so we have a study called Professional Referral to Physical Activity, Sport and Exercise proposed. And we're lucky enough to have some MRFF funding for that, initially through Sydney Health Partners, and then a larger grant from the MRFF directly in the health promotion area. And so we've started by trying to understand the current situation about health professionals encouraging their patients to be more active. And so we've done that with surveys and also focus groups. We've started with physiotherapists, but included some other professions as well, particularly rheumatologists and rehabilitation physicians, and some exercise physiologists. And so we've been doing these surveys across 2 different local health districts to kind of understand the context a bit more. And we were very encouraged that basically all the physios surveyed anyway, and actually most of the health professionals did consider promotion of physical activity to be part of their job. 62% reported discussing physical activity with over 50% of their patients. But there was obviously key barriers in actually doing this. And so one of these being competing priorities and limited time, as well as limited skills in supporting behaviour change, as well as limited knowledge of or knowing. So in terms of suitable exercise opportunities, either the health professionals didn't know they existed, or perhaps they actually didn't exist. And we think there's actually both of those things were going on. There was also a little bit of an issue that came up with a bit of a lack of trust in community programs. And so that's where I think those sort of accreditation systems like they have in New Zealand, could be really useful, as well as having greater links at that local level between the health professionals and also the exercise providers on the ground. And so we're actually doing various other studies in this area, but it's obviously a little bit challenging at the moment with COVID, with health professionals being quite busy. But we did also do some qualitative work, and so this is from Kerry West, one of our PhD students, who's actually also the head physio at the Children's Hospital at Westmead. And a great quote from a physio kind of became the title of her paper, which is, "People associate us with movement, so it's an awesome opportunity." And so, it was really quite telling that that people really, physios in particular, really did consider that to be part of their role. But then we've developed a model and a figure for what we can do to actually support people more. So understanding the barriers, so the difficulties, putting things into practice, the aspects of the competing priorities, aspects of barriers at the client level, so often cost, transport, support, difficulty finding information, and that issue with connections, building confidence. So the issue with really needing to trust those local opportunities. And so now we've developed some interventions that are based on knowing that information. And so also in terms of trying to do more with implementing effective fall prevention interventions, we've been lucky to gain funding for an NHMRC Centre of Research Excellence. And so we've got a very multidisciplinary, multi-state, multi-institution group of people. So they're our chief investigators and also a very impressive group of associate investigators there. And so we have 4 aims. So we're aiming to have better use of existing data. And we've started an analysis of the Australian longitudinal study of women's health, working with Julie Biles. And that's to understand more about kind of longer term physical activity and falls and how they interact over time. And then, as we've talked about, you know, really needing obviously to be consulting health professionals if we're wanting to develop interventions that are likely to work, and really working together with health professionals in co-design. And so we're also doing some work in hospital inpatients, as well as particularly in hospital outpatients, to look at how, you know, we can get those efficient referral pathways. And so then we also are hoping to do some large implementation trials. So if people know about CREs, they don't necessarily give you enough money to actually do the research, but they give you the resources to have a kind of network to better work together. And so one of the things that we've been doing is basically submitting further grant applications. And so that's with better implementing interventions that we know are effective. And so here we've focused on the community. And so we have applications in that involve that kind of referral pathway from hospital clinics. And an unsuccessful one that was about embedding this type of exercise program more into general practice, and actually enabling physios to deliver that through telehealth. But maybe we'll have better luck next time. And so I've focused a lot on the community. And that's partly because we actually are not so sure how to prevent falls in the other key settings in which they happen, and where they're highly associated with injuries. And so particularly in hospital inpatients, and also in residential aged care. And so here we really need to develop new interventions, and we're using also co-design type of approaches and really pragmatic trials, and getting into a hybrid effectiveness implementation trials where we're testing effectiveness of interventions, but also trying to understand the implementation aspects of those. So I think that's a rapid overview of all things falls in the community. Well, not all things, a selection of things falls in the community in Australia. And so by way of conclusion then, we know that structured exercise targeting balance and function does prevent falls in community dwelling older people. And that the Global Action Plan for Physical Activity, I think, provides a useful guide for kind of understanding solutions. And that, to me, better accreditation of community exercise and also better referral pathways could be really useful next steps. And I'll just take the opportunity to plug our conference that's coming up. So we have the Australia and New Zealand Fall Prevention Society, and this conference was actually meant to be in Auckland, but we've decided to go online. So we'll still get to see each other, but unfortunately we'll miss out on the trip to Auckland. And live stronger for longer, being the motto that also comes from that work in New Zealand. And just thank everyone involved in all of that, and a little bit of my my modelling of my social norms that you know, middle-aged women can do things like the City to Surf, albeit quite slowly, but having fun doing it. And yes, let's hope we can get back to that sort of thing in the somewhere in the medium term. All right, thank you very much for your attention, and yeah, let's have some questions and discussion. Thank you.
Terrific. Thanks very much, Cathie. That was a wonderful and very comprehensive and clear overview of all of the aspects of fall prevention that you're involved in, and your team as well. Really, really interesting. So just to remind everybody online, if you could please type your questions into the Q&A at the bottom, excuse me, bottom of your screen, and I will read those out so that Cathie can respond to them. So look, I've only got 6 questions for you, Cathie. No, there's a lot of really good things. So I'll start off with 1 or 2. Maybe I'll pick up on the, interested in the financial and economic sort of aspects of your talk. So the first one was whether your team are looking at updating Moller's costing from 2003, given that there are, obviously there's an increasing incidence, but there are a number of new interventions, and I dare say more in the diagnostics as well that might contribute to costs. So yeah, so interested in that. And then the second question would be, with regards to exercise prescriptions, whether there are reimbursements or incentives for health professionals, such as Medicare item numbers, that also might reduce out-of-pocket costs for individuals. So yeah, so updates on costing and exercise prescriptions.
Excellent, both very good questions. I mean, personally, I'm more about the interventions, and so, but yeah, I can see that the Moller work really does need to be updated. Particularly, we're now kind of within that that exponential rise. So probably won't drive that myself, but I'm very happy to collaborate with anyone who's interested in doing that, because yeah, I agree, it does need to be done. In terms of the exercise reimbursement, yeah, that's a really good question. Basically not. There's a bit, but it's not enough. And so there is the, in Australia, the enhanced primary care sort of chronic conditions funding. And so people can actually be referred from their GPs to have, I think it's 4, might be 4 or 5 allied health visits over a year. There's a few problems with that from my point of view. I think the GPs actually get as much money to write the plan as the allied health professionals get in total to deliver the interventions. And so it's, it's a contribution, but it's not actually meeting the costs of those health professionals doing that. The other issue is that it is only for people with chronic conditions. And so often those people are actually needing other types of interventions as well. And a lot of people, that program is actually used a lot for podiatry, because, podiatry is very hard for people to access. So yeah, there's a bit there. And I have been involved with submissions to try and get that expanded, but that has not been successful. And
yeah, it is interesting, and yeah, I see some parallels with other submissions for particularly MBS items to fully cover costs that are shown to be effective and cost effective. Sorry,
I'm just one more on that. I was just going to say the other thing that's happened is that some interventions in this area have been tied in with health funds pulling back from funding complementary activities, and have said to not be evidence-based, which obviously a lot are not. But yeah, some of the fall prevention interventions I think have been affected by that as well. So.
Right.
Greater need for advocacy.
Sure. Yeah, absolutely. Okay, so thinking a little bit about some of the studies, and these were questions that came to me. You talked about from the Cochrane review that many fall prevention interventions can work for people of all risk levels. And I was interested in your thoughts about whether interventions should target higher risk candidates rather than sort of at the population level, which I guess is more the, perhaps overall prevention, healthy aging. In that those who, particularly for exercise interventions, those who already exercise regularly might be unlikely to achieve any additional benefit. And just interested in your thoughts about risk and existing baseline exercise levels.
Very good question. So I basically think that we need to do both. And so those trials have kind of shorter follow-up periods. But it kind of makes sense, physiologically, and there's some observational evidence to support the idea that it's actually about kind of life course physical activity and exercise. And so we actually need to be, encouraging people to become more active throughout life. And to do the types of activities that are likely to promote balance and strength. And then particularly starting in middle age. And so we also have Anne Tiedemann has a program of work, focusing on people in middle age to get us to start doing these types of intervention. Over 50 basically. Right. So that's one thing. Interestingly, so in the Cochrane review, we were only able to do a subgroup analysis by how people were recruited into trials. And so there was the same effectiveness, the same relative effectiveness if you just recruit people from the general community versus having some type of screening for increased risk of falls. And so that's where we kind of get the conclusion that actually everybody needs to be doing it and we need to be promoting it to everybody. However, and the interventions have the same elements, so in terms of targeting balance and probably strength as well. But the actual interventions might look different in higher risk people. And so they can still be effective, but probably in reality, they will need a more skilled instructor to be able to be safely delivered. And so I think that we do need to look at more sophisticated messaging and having kind of referral pathways and algorithms for like which people can actually go to general community exercise and which people might need some more specialist instruction. The other thing is that there are other risk factors for falls, and so and that's a whole other debate about whether we should actually be having multifactorial programs that target a whole range of risk factors, and possibly we actually should be for higher risk people, but it's a bit hard to tease out because most of those interventions actually have exercise as well. And so my sort of message to people is that, well, let's start with exercise. Let's have it tailored according to the person's need and level of risk. And then let's add other interventions, other evidence-based interventions if warranted.
Right. Okay. Yeah, that makes sense. Thank you. Okay, so I've got a couple of other questions coming through. This one's from Renato Santos. Hi, Cathie. Do you think that providing physiotherapists with behaviour change knowledge to influence and increase motivation of older adults to engage in fall prevention programs could be a good strategy?
Yeah, definitely. And that's actually it's not specifically about falls, it's on physical activity promotion. So Leanne Hassett from our group is actually doing a study in Southwest Sydney, which again is on hold with COVID, but actually working with physios there and giving them more knowledge and skills about behaviour change so that they can be kind of having those type of conversations and embedding that into practice. And I think within physiotherapy generally there's increasing awareness that we do need to get a lot better at behaviour change and coaching approaches. That it's the old-fashioned idea that you give people exercises and they will do them, I think is now clear that that things don't work like that. So I think there's
So following on from that, a question about, particularly in the research studies, how you assess fidelity of the exercise interventions. What have you found have been the best ways to really understand, whether people are carrying out, I guess, their prescriptions the way they've been prescribed, and any difficulties they might have with that that then could be modified. And I guess along with that is your thinking around long-term adherence to physical activity interventions, and what might be the success factors for that.
So definitely both of those really, I think, are about behaviour change and sort of coaching approaches. And so, in our trials, we use sort of motivational interviewing approaches to really kind of engage with people and sort of work out what their priorities are, what their other commitments are, what's going to be realistic, and then also what they actually enjoy. So, and then sort of helping them find those types of activities. And so, it's the same as people at any age. Some people prefer to exercise by themselves, other people prefer to exercise in a group. So, and then luckily it's good that there is a body of evidence, and different delivery methods can actually be effective. So it's not as though there's sort of one single approach to exercise for falls prevention, because basically people do need to keep doing it. And so it really is about setting a plan that's going to be feasible and that's going to be either enjoyable or not too distasteful for them. And that's where often, that's why also I think the focus on community exercise is useful, because there, the social aspects can take over. If people are interested in those aspects, it's not for everybody. But we've actually worked with a few providers who've had people coming along to their groups for 30 years and really enjoying the sort of social aspects of those. But then we do also need to look at different delivery methods, and bearing in mind the diversity in older people and the fact that people are working later in life as well. So a lot of exercise for older people is 10 a.m. on a Monday, but it's not going to work for a lot of people. One mechanism for that also is potentially technology, and that's a little bit of a COVID silver lining as well. One of our trials that also Anne Tiedemann is leading is actually looking at yoga for falls prevention, and switched to being virtual classes, and has been inundated with people wanting to attend. So that's could be something that will have lasting impacts.
And so just following on from that, with COVID and certainly the lockdown restrictions, have you or your group been measuring the impact of that on physical activity, and I guess the opportunities that might come out of it, as you say, like virtual or Zoom-based yoga classes?
I think it's been, so we haven't been measuring it. I think it's been very mixed. So I think, some people and a lot of, people who are working at home actually kind of are finding it easier to be more active. But I think people who relied on like coming together as a group and perhaps needed some assistance or some kind of expert instruction have actually suffered and have lost out on opportunities to be active. Also, obviously, with health systems being in crisis and, understandably focusing on the COVID response, then a lot of other, services are not happening, including kind of outpatient exercise or even any outpatient appointments.
Yes,
So
and prevention,
Yep. In the UK, there's actually some data about increased falls since COVID because of the kind of deconditioning associated with the restrictions.
Oh, interesting. Yeah, and probably, you know, subsequent decreases in quality of life and well-being without those physical and mental health connections.
Yeah, definitely.
All right, well, Cathie, we are now at the end of our time. It's been a terrific webinar. Thank you very much. And yeah, on behalf of HSRAANZ, I'd just like to, you know, wish you well with your very, you know, impactful and important research. And yeah, look forward to more opportunities of working with you and your team. So I'm sure on behalf of everyone who's participated today, we're very appreciative of your knowledge and insights. It's been terrific. Yep. So thank you very much. And I'll bring this webinar to a close. Please don't hesitate to check the HSRAANZ website for future events, including those that I mentioned at the beginning of this webinar. All right, have a good day, everybody. And thanks very much, Cathie Sherrington.